Welcome to the Health Workforce Technical Assistance Center's webinar series. This webinar is entitled Preparing an SDMS Statewide Provider Data Upload, Two Comprehensive Approaches. And it was presented by Eric Turer and Barry Lacy on August 17th, 2017.
Hello, my name is David Armstrong and I'm the Director of the Health Workforce Technical Assistance Center. In today's presentation is about two comprehensive approaches to preparing an SDMS statewide provider data upload. Our presenters today are Eric Turer, a Senior Health Services Consultant at JSI Inc., and Barry Lacy, the Manager of Community Development at the Illinois Primary Health Care Association. Now, after today's presentations, you may ask questions either by using the raise hand feature, at which time I will unmute your phone, or by using the chat panel at the right of the screen. Also, when today's event ends, you will be directed to a short evaluation survey, so please take a few moments to provide us with your feedback. We would greatly appreciate it. Eric, would you like to go ahead and take over from here?
Yeah, thanks. Hi, everyone. Let's see, I've got to share my screen, and then we can get going. There we go. Hopefully everyone can see the screen now. So just by way of background before I jump into this, I'm with JSI, John Snow Inc., and we actually do statewide designation work with a number of different states and have for quite a while. And so this presentation is not targeted to any one particular state. I've drawn some examples from the work that we've done, but it's provided a pretty good sense of the cross-section of data available and how it can sort of be leveraged for this process. So what I'm presenting today is really what we've sort of worked out, and I'm presenting it in a kind of I guess I'll call it generic circumstance. So I'm not trying to focus on if one organization, if one state or one data set has certain characteristics or not, and I'll talk a little bit about that, but I just wanted to kind of make that clear. And again, this is just an approach that we've worked out. It's not necessarily written in stone that there's anything necessarily right about this, but it seems to have worked pretty well across a number of state situations. Before I get into it, I just wanted to talk a little bit about this concept of SDMS validation, as it's been called. And certainly, the point is to address the SDMS records. But I always want to make sure people are thinking along the lines of it's really bigger than sort of just looking at the SDMS and validating the records that are in there. It's really looking at all the known provider data and trying to integrate it. So what I'm trying to describe today is sort of an integrated upload, sort of a full state or a full state within a discipline upload of all that's known, sort of integrating all the different data sets. But when I say it goes beyond just the records that are in there, I like to talk about invalidation, which I'm hoping everyone's focused on, which is basically omitting records that are in SDMS that don't exist. So a lot of times it's easy to sort of find attributes of the records that are there. But if the records that are left untouched are still in the system, you can end up with a lot of extra capacity that doesn't really belong in your state. I will say, I'll just call out for Massachusetts, we started out with, over 15,000 FTE when the final FTE was around 6,000 or a little above. So obviously if we'd left that would have caused some major problems across the state. The problem with that is it's hard to, what I call, prove the negative. So, there's no way to sort of know that somebody's not there. They're not there to tell you that they're not there. So you're looking for proof or other evidence that they're not there that will give you a reason to invalidate them. That can work better or worse, depending on where you are. The next two, I think, are pretty straightforward in the validation. You're correcting and adding addresses and updating all the capacity and status information. The last piece is another one that I'm not sure sort of everyone had been focused on initially, which is also the addition of other valid capacity that's not already in the state. So when you're done looking at all the records in SDMS, there's going to be capacity that you see in your survey or in your licensure or in your potentially claims that is not already there and has to be sort of manually added. I'm going to start off saying it's a complex task. I've found it to be, even working with this data for a long time. Every discipline, every state has been a different scenario, so you can't just create one sort of template and then apply it across the board. Depends on what's available. It can change year to year. Not just because the data can change, but also like this first pass that we've done, we're starting with kind of a blank slate in SDMS. It's all sort of new data, raw data a lot of the times, but that's not always going to be the case going forward. So in future, you might have to take into account what of the data that's there needs to be kept versus changed. The relationships between the data sources are multidimensional and complex and not always consistent. So my classic example is I see claims being generated at a particular location, but I'm not seeing hours from a survey at that location, so now I have to reconcile that issue. There's a difference between overwriting all of the capacity versus uploading just for a particular area or particular attribute. So you might be adding claims where you've already got hours in, and that sort of changes the equation. The other thing that I'll mention here, I know this presentation is based on the idea of kind of working through each record separately. I know some states have done a thing where if you're uploading everything from scratch and you have full provider data, some states have sort of taken all the capacity out up front and then sort of uploaded the capacity that they know exists. That's a different scenario than what I'm talking about here. It's cleaner in some ways, but it's also more complicated to make sure that you have everything. The other thing that I'll say is data that we used to discard, or I know I used to discard, now has a lot of value. If I have specialists, I used to just take them out of my licensure data. Now that's valuable information. I can see whether any of the records in SDMS are for specialists and take them out, or if they have inactive licenses, things like that. So I'm now looking at a much broader set of data than I used to work with. Whether you have full or partial information is pretty important. So if you know that you have a response from everyone in your state to your survey, then you can do things that you can't do if you've got, a 2/3 response rate, because you don't really know for the other group whether they exist or don't. And the last thing is this is based on secondary data. This is all based on data that's kind of in data sets and databases. In the end, and if you look back at some of the claims analysis presentations I've done, sometimes what you'll find is that there's more work to be done, especially if it's like organizational claims and things like that, where you may not totally be able to say that every claim without doing additional manual work belong there. I think it starts with a very clear data inventory, and these are all framed as questions purposefully. So the license list, one of the key questions, do you have MPI numbers in your license list? The example I'm working with today, we do. We did have full MPI numbers in the license list as part of what's collected at licensure. If that's not the case, then you have less ability to know that you're not, if you don't match to the license list, that person really isn't in the state. The other things, what other attributes are carried by your license list? Inactive status, non-practicing status, suspended status, all that stuff maybe got thrown out before. Now it's relevant. This state that I was working with had a resident status for the license list. And also specialty versus specialties. Some states carry more than one specialty, so you might see an internist, but then you also might see cardiology, and that might cause you to change the way you view that provider. The statewide survey, you've got your MPI number, which may or may not be asked. I really encourage everyone to make sure you start asking the MPI number in your surveys if it's not already known. And also the organizational or practice MPI numbers. And that becomes into play with the claims data. If you have claims that are being billed at the organization level, it's really the best way to be able to connect your individual providers up to your organizational level claims. And And without doing that, obviously, if you look back at those Medicaid presentations, it's possible to lose a lot of Medicaid claims capacity. So that all has to get, because of the way SDMS is set up around individual MPI numbers, it all has to get back to individual MPI numbers. Do you have multiple sites in the statewide survey? Is the practice setting, is the role recorded by location? Do you know locum tenens? What about non-respondents and partial respondents? So, that's something to also think about. If you're uploading the data from the survey and there's pieces missing, are you aware of that? Is that going to end up in that upload file in a way that you weren't aware was going to happen? And then the all-payer claims versus the Medicaid. So we generally work with Medicaid claims. That's the only kind you can use in designation. Only thing I'm going to say about all-payer claims, if you have the all-payer claims data and it has Medicaid in it, what we tend to do is get that data set instead and then process the all-payer so that we're getting a count of all claims versus Medicaid claims. That's a great way to know if someone's providing care at basically all locations as opposed to just locations where Medicaid's accepted. So you can leverage both of those, even though you can't really use the all-payer data directly. What kind of MPI numbers do they have? Do they have a servicing, a rendering provider, an individual provider, or just a billing provider, which is often an organization? Can you link to multiple practice addresses? And then I'm not going to talk about the claims analysis process. This is a link. I don't know whether we'll send out the thing, but the Health Workforce Technical Assistance Center has recorded those previous sessions if anyone wants to go back and look and see the details about analyzing claims. J1, NHSC, those lists can come directly from the state sometimes. Dental auxiliaries for the dentists can be a separate licensed data set that you can pull on. So there's a lot of different things you can consider whether you do or don't have. Quick run through of the process. And again, this is our process. Don't take it as gospel. It's just the way we found to do it that I think has proven pretty useful. The first thing that I think folks miss is geocoding of tables, address standardization. Addresses are all important in the SDMS system. And obviously, there's 50 different ways of spelling or writing one single address. So the best thing you can do if you have the resources, either you have GIS or you can do this through some online sites, is geocode all of your data sets. And I even re-geocode the SDMS data, even though it's got a lat-lon in it, because I want addresses that I can match directly as though they were unique identifiers. Believe it or not, the geocoding's not a science that's always the same. You can run the same address through different engines and get different results. The other thing is you can match on what they call a standardized address, which is a single string that lists the whole address and fixes things like RD versus road and things like that. Or the latitude, longitude, you can actually sort of combine those into one field and make a unique ID out of it. I do all the work in Access. I know some people talked about doing this in Excel. I don't think it really can be done easily in Excel, not with the full range of options. And then the next couple of pieces are the way we actually process things. So looking at all the different things that you have to manage in terms of each record that's in that data set, what we start doing is creating a flagging scheme where we thought about what are all the key attributes or characteristics that we need to know about each record in SDMS. And basically, we added some fields, and I'll show you how that works, to the download table. So we start with that SDMS download table, and then we add a bunch of fields that I call flagging fields, which are just basically fields with X's in them to tell me that this is true of this record. And each of those is a separate query that sort of populates those fields, and I'll kind of show you that in a little later in the presentation. The other thing, so once we've got that whole base file from SDMS built out with all the flags, we build queries to basically create the equivalent of an upload table. And we use those flags first to pick the records that we're going to upload in each batch, and then we alter the fields that are pertinent for that scenario. So, if you're omitting, I'll talk about these in a little more detail, but if you're omitting, you have to give a reason code. If you're updating a record, you're going to update everything you kind of know about that record, the claims and the hours and the NHSC, anything else you can do. And then the key is to make sure you're not touching records twice. So basically, you can compare your upload file to what's left in your original file and make sure you're not processing records that have already been touched for another reason. And that's why the flags are interesting, because they can tell you, okay, this was true, but this is also true. So make sure you're not sort of bringing in providers in one batch that sort of actually have a different set of attributes about them. The other thing we do, which I'll show you, is we comment. Every upload is a comment field, so we remember why that record got put in the upload. That's very important for going back and troubleshooting if something goes wrong, or to figure out why that particular record looks the way that it does. And I can't emphasize enough, this import user guide tells you everything that this upload file wants. And so if you look through that, make sure that you're not mischaracterizing any of the things that, because basically it'll just reject if you don't follow those rules. If you look in that metadata tab, there's 2 tabs on that download file. The second one gives you all the attributes. So how are you supposed to spell the provider specialties? How are you supposed to spell the reason codes for omitting things? And and they're not always obvious. Like a couple of them have a period at the end for some reason, and so you've got to have that period or it will reject. Okay, more of the process. Again, I mentioned you have to then go and add the non-SDMS records. So that can consist of 2 different things. Secondary practice addresses. So you might have already added this MPI for one practice address, but they work at more than one place. So now you're going to have to add that second practice address as a new address for that provider. And also valid providers that are not in the state's list. So obviously, we might be doing Massachusetts, the provider might still have an SDMS in California, and so now we've got to drag that SDMS and give it a valid Massachusetts address. The last thing is, after we've created that upload table, there's some things we do acting just on the already created upload table. So for those added records, it's easier to sort of fix those specialties, make them the standardized specialties in that situation. Recheck, make sure we didn't miss any of our NHSC providers that were in that second batch of uploads. And then that allocated claims process that I mentioned. So if I've got organizational claims, they will not have been assigned to providers individually. We will have to say, okay, this organization has, 5,000 claims, so we're going to have to co-locate providers that we know are at that address where those claims are being generated and attribute that capacity to those providers on top of what they might have generated individually. So that's a complicated process, and you have to make sure you don't go over the cap. So if someone, you can't give 4,000 claims or 5,000 claims, sorry, for a physician, if they're already generating 1,000 claims, because you'll just be losing that excess capacity. So hope that makes sense to folks. The Medicaid processing description that I showed you for that YouTube link for the previous webinar says more about that. And then you export to the upload file. I include everything. So I don't just upload what they want. I upload all of my flags, the comments fields. The system doesn't care. It'll ignore those files. So just keep them all in there. It makes life much simpler. And I add a row number, because if you ever looked at the reject file, it just gives you a row number and an MPI number, and that's not enough. If you haven't kept track of it or you've resorted that table, you're kind of in trouble. So I add a row number to that upload file before I upload it, so I can go back and look. And again, I want to keep moving because I want to make sure I leave enough time at the end to show something, and also for Barry's presentation. So flagging examples, this is just a list. I'm not going to go into details on everyone. Hopefully they make sense. The first one, PC eligible. So when I'm doing primary care, I only want to work first with my eligible primary care records. So I just create a flag so I don't have to go back and add logic for that on every query. Then I look and I say, do they have an MPI match in the license list? So do I see an MPI match? Again, if it's comprehensive, I can tell if they're not there, if they're not licensed, I can take them out. If my license list doesn't have all MPIs listed, then I've got a different scenario. I can take some out, perhaps, but I can't say that if I didn't match them on MPI that they don't exist in the state. Claims, same thing. Do I have claims? And then I look and I see, do those claims match the actual address? Do the license match the address? Do the claims match the address? Is there specialty primary care or not primary care? Do they have something that would tell me they're not practicing, inactive, suspended, limited license I use to get residents? Non-primary care or public work setting, do they work in long-term care? Do they work in a hospital? Do they work in a in a setting you wouldn't normally count? Did they say they have 0 clinical hours on a survey? NHSC J1. The FQHC location I use as either a back check or a forward way of making sure I've got sliding fee, at least at the FQHC location, so I can match them to those sites where FQHCs are. So now I've got a flagged out claim. I'm going to jump for 1 second, and again, hopefully everyone's following. I know I'm going through this a little bit quickly. Let me just quickly sort of show something. So here's the SDMS. Sorry, I'm in Access right now. You can see I've got a bunch of data loaded over here and then a bunch of queries. And again, if you're not familiar with Access, it's pretty accessible software. This looks just like the download file. You've got your action, your MPI number, first name, and you can see I've scrambled these a little bit, so it's not revealing anything. But what I wanted to show is if I go to the end of what would normally be my license file, I've added some things. I've added the geocoded matched address, Latlon, which put those away. And then here's all my flags. So PC eligible, all I'm seeing is my primary care eligible flags. Did it match to the license? Well, some did, and you can see some didn't. Did it match to the claims? Less matched to Medicaid claims because they might not have them. Who matched to an exact match to the address on the license? A lot fewer of them. So now that presents its own set of circumstances. And again, here's people who flagged as specialists in licensure. So I'll have to remove those. But now I know. So this person, matches to the license list. I don't have their address, but they are a specialist. You can kind of see how you can build a scenario around these different flags. So that's all I wanted to sort of pause and show right there. Okay, now building the upload table. And so the upload table is built in Access. It's not built in Excel. It's just pasted in there at the end. Basically, the format for the download table is the format you need for the upload table. So basically, you create a matching upload table that has that same format. And again, I add a column field to track the uploads. I determine what the groups are that I'm going to do and the processing order. And I'll talk a little bit about more of that on the next slide. But basically, the order is kind of important. You want to make sure that you're eliminating or processing people with the best information you've got for each group, and then dealing with what's left, and that what's left should have a different scenario that you couldn't have covered in a previous group. And then basically what you do is you append each, what I call cohort, or each group of provider records to that upload table. So you pick out the flagging scenario or combinations that make sense for you. You link in these other tables. So you link in your license table, you link in your claims table, you link in a survey, anything else you have, NHSC J1 list, whatever it's going to take to sort of populate that data. Pick the action. So obviously, sometimes you're omitting, sometimes you're adding, sometimes you're updating. I'll explain that a little more. And then you modify what I call the key fields based on the available data. So you're really not touching most of the fields. Usually all you're doing is changing the hours, one or more attributes of Medicaid, so either the claims or the percent from a survey or both, you can do that. The sliding fee number, if you have the sliding fee data in a survey or in some other form. Sometimes at the organization level, you can match folks up and do sliding fee at the organization level. NHSC, J1, resident interns, if you have data on if they're at a prison or something, you can do that. So all those characteristic things, but a lot of the data that's in there, you're not changing. It's either part of MPI or you just can't touch it. So you copy forward data that's not changing or leave blank. These examples I've copied forward. The only danger there is in subsequent years, if there's things there that you put there that you didn't want to bring forward, that might be an issue. When we're starting from scratch, copying forward's okay because, it'll default to 40 hours, and if you haven't changed it, it'll stay that way. Again, the comment I already mentioned about adding these comments, and I'll show you some examples. Check the remaining records at each step against the uploads already done. So you'll see in the logic, you'll link the existing file to the upload table and say, make sure that the record that I'm uploading hasn't already been put in that upload table. And then that'll help keep track of not duplicating. So here's some examples of steps that I take in the upload process. Omit. So the first thing that I like to do is all the omits. Anything I can find that I can get rid of, I do that first because it's simple logic, and once they're gone, particularly if it's like at a provider level, like an inactive license or a non-primary care specialty, those would be good to get out first because you're taking the whole provider off the table from the beginning, and then they shouldn't appear in subsequent uploads. So, you know, if they don't have a license, they have an inactive license, et cetera, suspended license, their non-primary care specialty is in their license. The work setting thing, now you're down to something that might be address specific again, so you got to look at both the MPI and the address. You know, but is that work setting, is that particular place, you know, say a nursing home? You don't want to upload that. Did they say something else about their in their survey that lets me know that they're not practicing, or they're not practicing, you know, outpatient primary care, they're admin, or they've got a research role or something like that. So I take all the omits first, and the only thing with the omits is the reason code. That's the only thing they really care about. So the reason codes can be not always the best match to what you know, but pick the one that works the best. And again, use that list that's available to make sure you're picking ones that are exactly the same as the way they spell their reason codes, because it's a drop down in the spreadsheet. Okay. The next thing I look for is address mismatches. So folks who I can see that they're there, but the address that I've got for them is not the address that the system has for them. And sometimes it's very subtle differences, but if that standardized address doesn't come out the same, I consider it a different address. So what I'll first do is omit the old address. Reason code was moved. Again, I don't know why they were there originally, but we'll say they moved. The one caveat, be sure you're not omitting a secondary location for that provider. So if you match on MPI, you don't match on address, you're tempted to go, well, that's not really the address, that's not really a valid address, but maybe it's a secondary address. So just because you found one record where they don't match doesn't mean there's not another record where they do match. You're looking for places where there's no evidence of capacity at the location in SDMS. So you can omit that address. But if you see them at another, here we're saying, but I see them at another location. So now I'm going to do one append as an omit, and then another record as an add. And an add is where I put their new capacity using the address information I have from my claims or from my licensure. Next step is the standard. This is the sort of the standard validation update. So the MPI and the address both match. So now you've got the location correct and the right provider. You update all essentially the key claims. I look at it in two different groups. If there's hours from the survey, because the system wants hours, regardless of whether there is or isn't claims. So if there's hours, we can work with that, and then you can link to your Medicaid data or your survey data and pull in the other attributes. If you don't have hours at the location, but there's some other indication of capacity there, like you've got claims apparently for that provider, apparently at that location, you're going to have to do some additional work. So sometimes we'll basically make sure that they've at least got 40 hours minus whatever location hours they have at another site, put that there for the moment, but that's probably not the end of the story. Ultimately, you probably have to do some follow-up. You need at least enough hours to cover whatever claims that you're saying are there. And then add capacity that's not already in SDMS. So you can't, on this step, you're not starting with that SDMS list. You're starting with the other capacity that you know about. So you're starting with your claims or your licensure survey data, rather than starting from your download. So now you sort of flip this process upside down, and now you're adding records to the upload file that were not already in SDMS. You get your address again from wherever source has the address information. And again, sometimes you have to prioritize, you know, what seems to be the best address, or are they both valid addresses? It'll depend state to state. Discipline you plug, specialty is going to come from probably your licensure, but it's not going to be the specialty SDMS wants. So you're going to have to fix the specialty maybe in the end. Sometimes I fix it even once we've dumped it out into Excel. It's almost easier to be the SDMS listed specialties. Again, modify any key fields you can. And again, recheck those flag characteristics like National Health Service Corps, et cetera, to make sure that the new records are not. Or, you know, as this is kind of evolving even for us, the idea of maybe checking the NHSC in the final upload file is another way to look at it. And then again, create the upload file. So now you've got the equivalent of the upload file in Access. Now you've got to get it into something that SDMS will accept. So basically, save a copy of your download file, and this upload table that you've created in Access, you're going to paste into the Provider Locations tab of your download table. So you're just basically overwriting that tab with the data. What I like to do is keep their column headings and then paste the data with the headings below it, make sure I can kind of line everything up and that I didn't accidentally lose things that I meant to keep. So I tend to upload all the data back to them. That's not necessarily something you have to do. You can cut it down just to the key data fields if that's easier. But again, I also keep all my additional column headings, so my flags and my comments. So you delete all the data in the Provider Locations tab, paste. The other thing, and the one thing I've gotten tricked several times is sometimes the zip code in the standard field is not formatted as text. So if you live somewhere in the East Coast where zip codes start with zeros, you get a 4-digit zip code instead of a 5. So just something to check if you live in such an area. Add the line number. So this is another thing that I think I mentioned before is very important. Start numbering at line 2. SDMS counts the heading as line 1. So if you want to be able to just automatically link back to the records in your upload, line 2 is your heading, or line 2 is your first record, and line 1 is your heading. So the numbering starts at 2. And again, if you have to do this multiple times, and I've found often we do, so we'll get some rejects, we'll look at those, we'll fix them, we'll come back, redo the process. All you have to do really is change the creation date in that metadata tab to the current time and date, and you can upload again. You don't have to re-download the file every time to do that. All right, a couple of things on tips, tricks, and checks. And these are just sort of good practice things. What I like to do is sum up the total hours by MPI number for the adds and updates and make sure that I'm not, because what can happen is you can have 40 hours at one location, 40 hours at another location, and now you're uploading a provider. You know, especially if they just didn't answer a survey for one site or something, or you added it because they've got claims and you didn't realize that's going to put 40 more hours. Look and see how many hours you have. You know, obviously they shouldn't exceed 40 hours across the state. Or re-download once you're done, once you've got this finalized, re-download the SDMS and run some checks on what's now in the SDMS. The other thing is check total, if you know that everything ties out, and that's a big if, but if you know that everything ties out to your uploads, you know, if I had, you know, 200,000 claims, you know, that I consider to be primary care, did my upload file ultimately account for that number or pretty close to it? There's a couple of scenarios where that won't work, like providers that have stopped practicing since the claims were generated. The reject tool is actually not a bad thing. I don't mind rejects. Rejects do work for me. So some of the addresses might, to me, they look like different addresses, but once I've uploaded them, the system says, no, it's a duplicate address. So very easy. You just take those records, copy them over, and change add to update, and now it'll work fine. So the system sometimes thinks that you've got an address that's the same even if you didn't think so. Sometimes it'll say unknown MPI. Usually what I find is the provider listed their own organizational MPI. So, you know, I'm looking for Dr. John Smith's individual MPI. I found the MPI for John Smith LLC, which is an organization, because that's what they put in their license data. Very easy to go on, look it up online, and fix that data. And then sometimes it'll tell you have to manually enter in geocode, so you can go on the web, you know, and find the lat lon on the web and put that directly into SDMS. Or I do tips, tricks, and discussions. I'm about at 2:30, so I'll go a little bit longer. Just wanted to quickly show you a couple of more things about the data set. And these are just, again, there's a whole sequence of these things. So I have, and again, ignore most of this stuff. Some of it's not what I'm trying to show you, but like if I look at flag queries, each of these was a query that I created. So, you know, I flag my PC eligibles, flag the MPI match to the PC claims, you know, the non-usable work setting, 0 hours, all these different things that I want to keep track of. And they basically amount to an X in each one of these boxes. Again, I added these fields to what came from SDMS. So here's query number 3, flag an address match to the license list. So what I did was I said MPI in my provider locations list matches the MPI in the license list because I had that field. If you don't, that's a different scenario. And then the matched address, I didn't use the address that was in there. This came from geocoding. So this is the string used for geocoding. And I did it on both sides of that. So I geocoded the license list, re-geocoded the SDMS download list, and now I know that that address will match. I actually find this works almost better than the X and Y for some reason, because this is a 6-decimal number, and sometimes for some reason it wants it to be the last digit is different. So I find the matched address actually almost a better way to line them up. But again, if you haven't standardized the addresses, this becomes a harder problem to solve. So that's it. And so a flagging query is literally the scenarios defined up here by this logic. The MPI matches, the address matches. All I'm doing is put an X in this column that I created that said address match to license. Now I can use that field to find those providers and anything else I might know about them. You know, because they might match to a license, but they might be a specialist. So maybe I don't want to treat them just as a match to license because I'll put capacity in there that I shouldn't. So that's the flagging, and then the upload is the next piece. So instead of looking at the flag queries, look at the upload queries, and you've got, and sorry that these are out of order, 1's up here, and then it goes to 2, 3, 4. It doesn't list things in a logical order. So the first one is an upload omit no license. Here's the logic for that. It's my first query, so you can see it's a make table query. All I did was take all the fields that are in my working download table with my added flags, and I just added them all as upload fields. So very easy. The only thing I'm doing to omit them is adding omit as the action. If I can find my reason code in here, which sometimes I can. Okay, so reason code. So everything else I'm just copying. Well, I also zeroed out their hours. So here, instead of just taking the field, I plugged the value, 0. Here I plugged the value, relocated. And then over in my flags, you know, it's an eligible provider, so there's an X in that column, but the NPI match to license is null, so I can take them out. Again, this only works because I have MPIs for all my licensed providers. If I didn't, this would not be a good thing to do, because you'll take out providers just because, you know, maybe if they didn't all answer their MPI, then you'd have a problem. But so that's the example. Yeah, so be careful as you do these to make sure that you know what you do and don't know about each provider. Here's another one, upload by work setting. So this is the second query. So this is work settings that are not valid. And, you know, if I go over, again, my logic is they're eligible. I say omit. I give a reason code, which not public access facility. So for whatever reason, their setting is not the right setting, so I called it that. And then over here, which I didn't show on the last one, but I did do it, my comment to myself that goes into that file, invalid work setting, and I add the actual work setting that comes out of the license. So I can go back and look and say, all right, I know what work settings caused me to throw that provider out if it's ever a question. And again, here is my check. I'm looking to my existing upload file that I'm appending into and saying, I don't see this provider already touched in that file, so it's okay to add them now. So this is an update address match. So this is just an update query. So I just wanted an example of an update query. So here I have matching examples, so now I'm just going to update that provider because I know that they match to the license, the MPI number, and the address. And if you keep going down through the list, you'll see there's the drop adds are in here. And then ultimately in the end, add non-SDMS capacity. So, oops, oh, sorry, that one's not going to work. I modified this a bit to sort of blind out some of the data and obviously crush that. But you get the idea. You would find that capacity and put it in as well. And then you can also see there's some upload fix things. This is acting on the upload table directly. So once I figured out who was FQHC, I can modify the update records in the update query directly. So ultimately what I'm getting to is this SDMS upload PC table, which is already here. And again, it's got, if you look at what's available, there are various actions, add, update, omit. And if I look across, some of them will have different attributes changed. If I go over to the comment field, here's all the different reasons that I ended up with of how these records got here. So here's all my invalid work settings, so educational, government, hospital. You can see what I was talking about. So I kicked them out for invalid work setting. I also documented what it was. Here's no license, no active license or inactive license. Here's the various reasons to omit people, re-adding, omitting first for address mismatches, and then re-adding the address mismatches. You can see what went on. And then in the end, the line number, and I know this is not quite right the way it is here, but that's what I'd upload. And then the last thing I'll show, and then I'll turn it over. This is the resulting, so again, this will look like your download table. But now the action, so I just paste that data into here. The action field is filled in for everyone, the MPI number. Again, names are a little bit scrambled so that it's not totally obvious, but you get the idea what would be here. And that would go all the way out to the end of what's in your normal download file. And then I add my extra fields, so I can always go back and look. I've got my matched address. These are ones where these are ineligibles, or for some reason, I don't know what's wrong actually, but they don't have an address that matched, so they're not ineligible. Let's see. So I've got records of all my flagging fields that were loaded, which for some reason I'm not in the data itself here. Oh, these are all the omits at the top. That's why. Sorry. Yeah, there we go. Okay. So now we've got data in the data fields. You can see some of them have different combinations of attributes that I would or wouldn't want. And then over here in the end, all I was going to show was I've still got my comments, so I can always filter and look. And I've got my line numbers starting at line number 2. So if it says that there was an issue on my reject file with line number 10, I can pull that file directly into my database and find line 10, or I can look it up in here and see what was wrong. So I'm going to stop there. Hopefully that made sense. I know I went kind of quick, but like I said, it's a fairly complex set of circumstances that you're trying to manage to figure out this upload process and get all the provider data from all these disparate sources to sort of play well, and also to play well with SDMS and its requirements around, individual MPI numbers and specific addresses and, all the other sort of things that relate to what an upload file has to have. So hopefully that made sense. Again, well, I'm going to turn over to Barry because I know I've gone a little bit past the time allotment, but we'll certainly leave time for questions in the end. And if anything didn't make sense, let me know now before we move on. But if you have general discussion questions, I think we'll talk at the end.
Okay, thank you, Eric. As always, that was very informative. Barry, I'm making you the presenter now.
Yeah, thank you very much, David. I appreciate it. And thank you, Eric. That was very, very informative. As an end user, I'm seeing it as what I need to do to make SDMS work, but actually seeing some of the internals there really is quite informative as well. Thank you very much, and good afternoon, everybody. My name is Barry Lacy. I am the Manager of Community Development with the Illinois Primary Health Care Association. I work on a grant funded for by the Primary Care Office here in Springfield, Illinois. I work very, very closely with the PCO, and I'd like to thank them first off for me butchering their slides that they had created, which these are about to go through. And when I refer to we in this presentation, I do want to give them absolute utmost credit, because there is a big team back here. When I say big, there's only 2 of us working HPSAs, but the number of people that were involved in getting this thing together is incredibly, incredibly thankful to all of those. So Diane, Yali, and the team there, big team committed to getting this data. So without further ado, what we came up with here in Illinois is once we had, all of our HPSAs sitting there in SDMS that hadn't been updated, we're looking at, somewhere to the tune of 230 HPSAs, 120 primary care, 80 dental, 27 mental health HPSAs that were cut up into catchment areas. We also had a great many in the urban HPSAs in the city of Chicago too, which there are thousands of doctors in some of those HPSAs. We're looking at this situation where we have a Delta file dumped upon us with the better part of 140,000 providers. Now that in itself was overwhelming. It was far too. We're looking at that. We're pulling our hair out for days on end, going, what are we going to do with this data? How can we get it to work? The majority of the data, thankfully, we only had 40,000. When I say only 40,000, that's still where we were 3 years ago. We were doing HPSAs on a survey-by-survey basis. These 40,000 doctors are right there, right now, and they need validating in the next 4 or 5 months. So it was extremely, the pressure was on us to get these MPI records validated, get them updated for low income, Medicaid claims, sliding fee scales, all that data needed to go in. So what we did there, thankfully, Shortage Designation Branch and HRSA obviously came through with some supplemental funding. What I was doing back here is doing my very best to do something that what Eric was displaying there, using Microsoft Access to match NPI numbers to Medicaid data, to the SDMS Delta file, and to the license data that we'd gotten from the state of Illinois, which did not include NPI numbers. So while we could match on NPI numbers from Medicaid to SDMS, we still had to do license numbers individually and manually, and that was just as much as a daunting challenge as it was by doing the Medicaid individually. So we received our supplemental funding, which is obviously gratefully received, and that enabled us to take it from me as an end user, to a developer, to somebody who can actually develop an application where we can throw this data in, and it gives us data on the backside that gives SDMS what it needs for us to validate all these providers. And it was extremely, extremely welcome. What they came up with was PCOMIS, which is Primary Care Office Management Information System. And what you can see here is essentially the data dashboard as to what the SDMS download file looks like. It's in a little bit of a different format. It just looks different. But here's the majority of what we see. We have included some additional columns, IDPFR status. That is the Illinois Department of Professional Regulation, Financial Professional Regulation. That is the department that deals with licensing in the state. And then there is SDMS annual Medicaid claims, another column that was added on our behalf, so that we can put those into the SDMS and then do the upload, which would essentially be a blank cell. We can now determine if these are active, and if they are active, do they have Medicaid claims? If so, how many? We can add that data in, goes automatically into the cell. Now, this solution really did give us a platform where we, in a few steps, in literally a few clicks, could download the data from SDMS, put it into this PCO-MIS system, along with a Medicaid file, along with a licensing data file, and it literally come out with the SDMS ready to upload on the upload import tool that you've been using, so we can actually do this in bulk. And very much like what Eric was doing, the first thing we wanted to do is get rid of as many data cells, and I'm going to call it data cells, they are providers, but essentially it's data, and the less data we have to work with, the better machines run, my brain runs. The less you have to work with, the less you have to look at, and the less you're looking at, the easier things appear to be. So we have our 3 data sets. Medicaid claims, we had 20,000 records. SDMS Delta file, the pre-validation was like 140,000 down to 128,000, down to 40,000. And then we had nearly 300,000 Illinois license data records. Now, just because we have that many records in Illinois licensing, that doesn't mean they're practicing physicians, they're practicing dentists, psychiatrists, or anything else. Those are just active license numbers. Oh, sorry, let me rephrase that. Those are actual license records, not necessarily active or inactive. A lot of them were relocated, revoked, suspended, or elsewhere, or just hadn't been updated. So all these 3 sets of data, they're all going to get pushed into PCO-MIS, and this is where the developer produces this application that does magic things to, make data come out on the other end, which is absolutely amazing. The first data set was our Medicaid data. We work very closely with Healthcare Family Services, which is the state agency which manages the Medicaid program in Illinois. They were extremely good at providing us with data that they had available to them that could make our data far more relevant and what we needed, so that SDMS could just accept it without much modification, if any, from us. It turned out it required no modification from us, which is extremely helpful because we asked them for rendering addresses, service rendering addresses, so that we can, instead of some of the license data, it's their own home, it's an administration building connected to a hospital, connected to a physician's group. There are a great many reasons why some of the addresses were a little off, but getting the rendering services address was a big plus in making sure that we actually had the providers working at that location. They also based it on, if you're familiar with the Medicaid CPT codes, the T1015 code, which is the code for a general service. That would be what a doctor would do during a 10-minute appointment. This code would pretty much go into all of them, so that any recurring codes, such as lab work or x-rays or wherever else, those would be omitted straight away too. So we were able to get those per patient, per appointment slot, per provider. We also have in Illinois, other states differ. Some counties have a fee-for-service. Some counties have a managed care organization. And in some cases, we have providers at different services rendering addresses serving fee-for-service and managed care. So you could have one provider legitimately serving or appearing on this list 4, 5, 6 times. And it was essential to be able to sort of, throw out some logic to be able to determine are those rendering addresses in HPSA A, HPSA B, are they even a HPSA at all? What is that provider's total number of claims for that address? And again, PCO-MIS was able to do that for us by separating the fee-for-service claims, the MCO claims, or in some cases adding them together, so that as SDMS, all it cares about is what are the number of annual claims for that provider, and that's what we were able to give it. We did have an example of an OBGYN in a rural county 2 days a week and an urban setting for 3 days a week. So it was going from fee-for-service to managed care, a different HPSA one day and a different HPSA the next. So those eventualities were able to be added in there. We were also able to get the organizational codes and the FQHC codes removed at the beginning as well. So all we were left with was raw physician, which included behavioral health and dental. We were able to have that separated as well. So most of the organizational codes we were able to omit almost immediately. With the SDMS data, the big Delta file that we got great NPI numbers, which was easy again to match as a unique identifier with our Medicaid data. Again, the biggest issue that we came up with to begin with was the provider license numbers. In talking with Eric earlier this week, I made mention that the majority of the inconsistent numbers that we had were actually from Massachusetts, where he was working. He explained that that's a big teaching hospital, or a teaching hospital state, so a lot of doctors that are coming from Massachusetts and going out to other states retain their 025, and I remember the numbers, quite vividly. So with the formatting, though, as Eric mentioned, with the zip codes, most license numbers start with a 0. So the first thing Excel does, Microsoft Excel or Access, is get rid of that 0. So instead of 036 or 025, we were having 3625. Then after that, we'd have a different set of numbers. Sometimes they were separated with a dot, sometimes a dash, sometimes a slash. And the first thing Excel does with a slash is it thinks it's a divide command. So you had 036 or 36 divided by the rest of the numbers. So very inconsistent. The addresses as well. Again, thankfully for the service rendering addresses we were finding in Medicaid, some of the addresses from licensing, some of the addresses from MPI, SDMS, some of the addresses from Medicaid, you'd have 3 different addresses for one provider. That was a little bit of a challenge, but where there was consistency, we did use that consistency. The specialty as well, the specialty in Medicaid was, and the taxonomies in SDMS, we were able to determine if there was actually an accurate and consistent specialty that went across the NPIs. The system, again, churned out. We gave it a list of the Medicaid and the taxonomies that were appropriate for SDMS, and the system did the rest in determining and weeding out those that weren't in there. Again, with SDMS data, as well as licensing and as well as our Medicaid, and this is something we have to do manually, we don't have any way of determining tour hours. The 40 hours a week that SDMS defaults to is pretty much the default that we've had to return to, because we don't have any other way of determining if that's correct or incorrect without doing an individual survey. Sometimes we've had to do that, and other times, we get lucky and find out those numbers from an admin source that is consistent for a set of doctors. A surgery, for instance, where all the doctors are at 32 or 36 or 40 or 44, wherever it may be. The FTE calculation is going to cap at 40, just like the Medicaid is going to cap at 5,000 claims as well. We did have a few claims that were crazy. There were 28,000 claims for one doctor. Those require a second look at. I mean, obviously, it's one FTE, whether it's 5,000 claims or 28,000, but we determined that there was a lot of PAs and a couple of unnumbered nurse practitioners that addressed too. And then there's the Illinois licensing data. This was very, very accurate in terms of this data is good right now. So the data what we have in it today, they are extremely efficient. If somebody's not licensed or somebody is suspended, revoked, or deceased or otherwise, they're extremely good at having that data available to us. So where the Medicaid data could be as much as 2 years old, an entire year has to go through a calendar cycle or an annual cycle, then the data has to get processed and the data has to come back to us, and we look at it, it's 18, 24 months old. The licensing data is accurate and it's fast and it's good right now. The numbers are very good as well. The address locations, again, we had a lot of residentials. in that because, you know, a doctor's registering where he lives. He may not have a job when he gets his license number or comes to the state or have any other information that would be different. So, and again, the only downside to this license number, we didn't have MPIs. What we did there is we did have date of births. We do have, you know, first, middle, last name. We were able to determine with a great deal of confidence that if Dr. You know, there's a lot of John Smiths out there. If Dr. John Smith is born on the same date and practicing at this address that's extremely close to what's in two different data sets, we were pretty confident that that data would be the same provider. So we went along with that. Now, for the data functions performed, I mentioned earlier that what we were looking at with that data dashboard, we had annual Medicaid claims and the license data, IDPFR status. We see that for 3 providers here, that the license data is accurate. So therefore, it's going to look at, okay, the provider's active. Does the provider have any Medicaid claims? In this case, they do. Also reverses that, okay, the provider has Medicaid claims, but is the provider allowed to practice in the state of Illinois? Just because they had Medicaid claims from 2016 doesn't mean that they're allowed to be practicing right now when we're updating that HPSA right now. So there's a check and then a reverse check on those providers. The source data that we have, like I said, 3 main sources. SDMS comes in, and then Healthcare Family Services Medicaid claims, and then IDPFR is the licensing data. So those 3 come in. These are the source data sets that we can look at. We can look at them separately, or we can look at them by the state or by the individual provider. Now, for the provider, we're looking at, we can look at an individual, in this case, Erin Riggles. We can look at the SDMS data dashboard for this provider, the Medicaid data, or the licensing data for this individual provider, and then we can look at and make changes. Then we can do edits to that provider individually. For this particular one, the data in the blue or the shades area in the middle, that's all data that we can make changes to. The other data is data that SDMS has locked out. We can't make any changes to that, so there's no point us getting excited with any of that stuff, even though I would like to be able to change the license number if some of them aren't, if some of the formatting isn't correct, just for our own ease of use. So we have the individual editable fields there, and we have whether we can update it, and in a reason code, just like Eric was doing with bulk omits and bulk reason codes being added in, we have that too. And if for whatever reason the licensing data comes back as negative or not true, then a reason code would go in there automatically to say that the reason for the omit is not renewed or revoked, and we would do those in batches. I tried very hard, but with the better part of 20,000 records, I didn't find any. But I did try to look for an example where on the same spreadsheet or the same screen, I could have updates, actually it would be omits, for license ineligibles and an update to add Medicaid claims, but I did them in two different areas instead. So here we can see a provider was recognized as having an ineligible license. SDMS we would make them ineligible. The reason code would be non-federated licensed in state. Just because of the IDPFR status there as being not renewed, that would throw up that reason code that would automatically be part of an update omit. And again, if the Medicaid claims are being updated, if we see Medicaid claims being added to a field, that would automatically generate an update that would add those together and update accordingly. So the outcomes were within an afternoon. Once we'd done some testing, we were able to provide validations for the 40,000 providers in Illinois in one afternoon. It was that good. It was, once the data came in, once we looked at it, once we'd done some testing, some bulk testing, some batch testing, and individual testing, and we were confident with it, we just went ahead and divided the state up into 5 parts. We capped the updates to 10,000 records. We didn't want to overload SDMS. We didn't want to overload our systems or anything in between. And it was easier to see any errors or identify any errors or be able to deal with those errors if there were any more than that. So we capped them at by region and by 10,000 records. So they all came back the next morning and looked at the upload status for those SDMS uploads, and sure enough, they were all done. And we breathed a very hefty sigh of relief, because, like I said, we were looking at 5 months we needed to get these validated providers in, and we got them in. And then came the, looking at some of the HPSAs, look at some of the RSA fails from the impact analysis to determine, okay, now that we've got this low-income Medicaid data in, has that affected any of our HPSAs? So we were able to quickly identify some of those and then quickly get to work at updating some of those HPSAs right away. So without the supplemental fundings, we probably wouldn't have been able to get it done with so much alacrity. With it and with the development assistance that we had, it was very brief. We had many discussions back and forth with the developer, who was very hands-on in terms of what does the output need to look like, what data sets do you have to start with, what did SDMS want, what was that initial, that final upload, what did that need to look like so that we could get the uploads done. And once it was done, we saved so much time. I don't even want to imagine the amount of time it would have taken to survey even 40,000, let alone the 20,000 Medicaid records. What we were doing back prior to that was literally asking them what the percentage of their Medicaid population was, which, having seen some of these Medicaid numbers actual by claims, they may have embellished those percentages a little bit, but nonetheless, we've got great data now, and this is reoccurring data. We can get the Medicaid data every year, pop that in, license data whenever we want. That's a basic download and then re-upload, and then whenever a Delta file is uploaded, we have that to look forward to. So without taking any more time on that, it's not as in-depth of what Eric had. Eric was clinical in what he was showing. As end users, without that ability to to program access and without MPI numbers for all of our data sets, and having a development team that was able to assist us, we did get great data on the back end, which is what anybody wants. That's going to save them time and money and be able to get HPSAs processed accurately. So again, I don't know, David, if we're going to do questions now or back to Eric for questions, or how do you want to do this? But I want to thank everybody for their time anyway. Thanks for the opportunity to get this information to you.
Thank you, Barry. And we can by all means start the Q&A session at this point in time. So once more, I'll remind the audience, if you have a question, feel free to raise your hand or use the chat panel on your screen. With that said, Eric, we don't really have any questions coming in just yet, so would you like to get us kind of started with some common questions you're asked at times?
Sure, and sort of just going back to what Barry was saying about, not having a survey, not necessarily having an MPI, those scenarios were part of some of the states and some of the disciplines, even in the states where we did have them for other for say primary care. And again, the scenario changes quite a bit if that's the case, and that's why I said, it sort of has to be thought through and developed around each discipline based on what's known. And I think what Barry showed was a great example. Once that's in place, there are some pieces that I think are always going to have some manual component, particularly, allocating the organizational claims to providers, you know, I'd be reluctant to do that, you know, even though we're sort of matching them automatically by address and things like that. I think the biggest question that I'm sort of faced with is, you know, how do we know it's right? You know, and particularly in the designated areas. And so I think Barry hinted at a similar process where, you know, you do as much as you can at the state level with secondary data and upload, and then you look at the individual designated areas and make sure that everything looks right there. Because you know, again, we're starting from a different place. We're starting from this MPI list with a lot of providers that never would have sort of made it on our radar screen in the past, and now they're on the radar screen, and we have to figure out whether we have good enough justification to take them off. So I think in terms of the questions, it's really once it goes down to the designation level. You know, when we look at the designation level, and we'll see things like, you know, providers who got organizational claims, but those organizational claims might include, I think Barry mentioned, you know, if they're billing as an organization and they have NPs and PAs, that's going to be in that count, and then you're going to have to go back locally. You know, I can't do that at every organization across the state, but I can do it in the designated areas where I'm relying on claims and go back and ask further questions, things like that. So in terms of questions, I think it's hard to say because we sort of started from already having worked with the data sets in each of the states. I guess really the thought is, are people running into places where they're finding pinch points in this process where we might be able to sort of brainstorm around them? Because there are definitely optional ways. Barry mentioned a couple of things. If you don't have an MPI number, can you do name and birth date match or sort of probabilistic matching, or can you do something that will work around that and get at least some, if not most, of the providers linked up? That's where I feel like some of it comes in. So I don't know if that's resonating with folks, whether this process looked familiar from either of our presentations to what went on in your states, or if you have things that worked better than maybe some of the things we talked about.
And Eric, we do have a quick clarification question, and either of you, I believe, can answer this. I just want to clarify that this process is solely for Medicaid population HWTAC designations, specifically because for a low-income population, Medicaid claims and sliding fee scale percent is required. Thanks.
Yeah, I'll start. It's not just for that. I mean, we tried to do the data analysis across the state. All because their request was validate all the providers, which, again, brought us into areas we never looked at before. Most of the providers are not in the places that have provider shortages. So we were now working with massively more providers than we ever had to for designation. So the idea was, again, to try, and in my example, I had survey data, and the survey data had an MPI. I had license data, and it had an MPI. So I could do things. In some of the other scenarios, I didn't have those things, and so it was more like what Barry said, so 40 hours. Obviously, you don't want your designation to just hinge on 40 hours in the end, so there you might need extra data. For the sliding fee, so yes, the Medicaid data will update that if you're doing a Medicaid only, but for sliding fee, that was part of what I was doing with the community health centers. We know that those are the areas where, at least in that state that I was looking at, most of the sliding fee is really only funneled through the health centers or the hospital locations in some other states. So we would focus on those sites and look to the providers that were at those sites, and then sometimes you can get the data for the organization as a percentage, not necessarily each provider, obviously, without surveying them. Other states, we had the data from the survey. We could bring in the sliding fee from the survey. So the idea was to try and basically set the base for all the designations from this process. But within the designations, I found it necessary to go in and then look at the providers that were there and make sure that I was comfortable with the level of capacity that and how it got there, because with those comments and all that we add, we can tell, like, all right, what put that capacity there? All right, well, we saw they had claims, but the hours were not on a survey, so now we know those hours might not be fully fleshed out, if that answers your question.
If I may add just a couple of things here. Illinois being an expansion state for ACA, we saw a tremendous amount less in the sliding fee category, but a great deal more Medicaid claims. So they balanced themselves out, but again, this actually came down to the individual designation as to, you know, what the claims were like before, what the claims were like afterwards, what the sliding fee was like prior to, how many FQHCs, et cetera, are in that designation, and what kind of a difference. But that isn't something that we looked at the state level when we had the entire batch of data going up. I wanted to center this more around Medicaid as opposed to sliding fee, but things like sliding fee and, you know, survey hours, tour hours, it's always going to come down to the designation level and a little bit more work. I hope that clarifies a little bit there.
Thank you, Barry. Thank you, Eric. We're still taking questions, and okay, I do have another question that just came in. Did I hear correctly you replaced the geo coordinates in SDMS?
Yeah, that was me. I didn't replace them in SDMS. I replaced them in our analysis. So I didn't touch the SDMS coordinates that were there, but I re-geocoded the SDMS data set to make sure that whatever matched address or set of coordinates that I was working with would match the other data sets that are not in SDMS. So when I geocoded the license list and geocoded the Medicaid claims results, you know, every time I saw the same location, you know, geocoding has built into it an address standardization engine, basically. And as long as you're using the same address standardization engine and geocoding engine, theoretically you should get the same result, whether it says, you know, first street or first ST or first ST period, whereas otherwise it's very difficult to know you've got the same location. And without being able to match on location, you know, the MPI is not definitive in terms of the capacity. So you could be seeing claims for an MPI number, but not at the place that your address is listed. And so that was kind of a key piece. It's built into the structure of the way they set up the SDMS that there has to be some way of controlling address, and unfortunately that's the best way to do it is to sort of take it out of that system. And I did some test matching to the SDMS LANs versus my engine, and they were not quite the same. So they'd be off by a few hundred feet. And again, that's more than enough to say that it's for the system to say it's not the same address unless you standardize. So yeah, but again, I didn't re-upload those points into SDMS, and I don't think it allows it.
Okay, thank you, Eric. Well, we're actually kind of down to about our last 10 minutes of this event. We are still taking questions, but at this point in time, I'll throw it over to you, Barry, and also you, Eric. Do you all have any closing thoughts or closing comments you'd like to share with the audience?
Do you mind if I start, Eric?
No, go ahead.
Eric definitely has a much more national experience level in terms of he's working with different states. ACA was a big deal for Illinois. We are an expansion state, so we did have an increased population in Medicaid. So therefore, you know, for data and ASAPs prior to 2016, for instance, we had, I'm not going to say bad data, but it was data. It was the best data we could get at the time. When you get these data sets from Medicaid agency, they're absolutely unequivocal. It's wonderful to be able to not have to worry about an entire data set that your RSAs, your service areas, and your HPSAs depend on. So the majority of the low-income HPSAs and Medicaid-only HPSAs, be they wherever discipline, have actually sailed through that RSA process in SDMS now. It's been really quite, from where we were a year ago, with SDMS, it's having a little bit of a push in a direction that gets you that data set that you don't have to worry about anymore. Certainly makes, like I said, we've got 280 HPSAs that you have to, because of the delay in updating them over the prior 5 years, you've got to do those now. And they've all got to come through again, which means every doctor and every HPSA in almost every county has to be touched in some way. So the less you have to do that, the better. And I think, the upload tool was certainly a big deal in getting as many doctors, providers, dentists, wherever, dealt with in as quick a way as possible. So that's my closing there.
Yeah, and maybe I'll just build on that a little bit. I think there's two things built into what we've been talking about. One of them is this process for creating bulk upload files of providers into the SDMS, and the other one is the idea of how to process Medicaid claims, which, again, thanks to David's group, I've done a couple of other presentations specifically on the Medicaid analysis process. I think there's still quite a bit of inconsistency in the way that this is being done from state to state. So I think the starting the dialogue about how everyone's approaching it is really important, just because in both of those processes, I totally agree with Barry that the ease of going from trying to ask providers what % Medicaid they take, to just pulling up their claims number, and the ease of creating a system that connects all these data sets and just, having that go into the system is great, and it's tantalizing. But I also, having worked across many different states and many different data sets, we rely pretty heavily on this. There are always flies in the ointment, and this is a bit of a black box process. Whereas, doing a HPSA in the past was sort of very hands-on. You saw each survey, you called or looked at the responses. This is now sort of going to a level where it's very streamlined, but it's also very there can be unexpected consequences. So I think it'll be great for everyone to now go and look and see how that matches, whether anything comes out in this process. Again, claims data, we rely on it very heavily now, almost exclusively if we can get it. But if you look at those Medicaid presentations that I've done, I talk a little bit about some of the pitfalls. Some of it depends on how the providers are set up to bill. If you have a provider that didn't get separate MPI numbers for every site that they operate, or didn't include the individual MPI of the provider that did the service, you can end up with all your capacity going in a place that you didn't expect it to go. And it's not easy to find that. Like, we find it by matching across data sets and say, well, there don't seem to be any licensed providers there, but there seem to be, 40,000 claims. What's going on? And then have to dig in. So I think it's a double-edged sword, and it's pretty new. So I encourage everyone to sort of, compare back to the way things were the last time that they were done using the old processes and see just, does it look consistent? Does it look like things have shifted? I think this is the way things ultimately will get done. And as people move to statewide surveys and statewide availability of Medicaid data, I think some of this work will ultimately be a lot easier. And once you've got the system locked down, like the programmers that created Barry's system, then you can replicate that system and save a lot of time down the line.
Okay, thank you, Eric. Thank you, Barry. And while you were speaking, we did get a couple more questions in. We are about at the end of the time we said we'd go, but Eric, Barry, not to put pressure on y'all guys, but do y'all have a few more moments?
Sure, I'm good.
Absolutely.
Well, with that said, here's the next question. Has any one of you accidentally created a duplicate record, that is by matching of NPI and address for a provider?
Initially, yes. I mentioned a couple of checks that we do along the way. What I didn't really point out is most of those things that I spelled out were the result of, two-step forward, one-step backward, development process for each discipline in each state where, you test and you hope you got every scenario. But I think there's one slide where I said some final checks that you can do. And one of them is, look at your upload file that you've created and sum up the hours across each MPI number, and then sum up the number of records across each MPI number that are adds or updates, not omits. And then, that's a great way to find duplicates. And then once you find them, unfortunately, then you're going back into your logic and figuring out how did that get there, and hopefully refining the logic of those queries to eliminate them, put them in so that they're in one, not more. The other way is once the whole thing's up in the system, re-download your SDMS file, and now you've got everything the system believes that you know about capacity, and that's a real great place to check. Count your records per MPI, match some on MPI and address C, make sure you don't have any where the count is more than one. So there's some back-end checks that you can do. But yeah, there's a lot of potential for that while you're creating the logic. And again, that's what some of that flags are there for, is to try and say, oh wait, I don't want to put that provider up here yet because they've got another characteristic that I'm going to have to do a separate routine for later.
When doing an RSA or updating a HWTAC, as you're doing it now on the individual HWTAC level as opposed to a statewide level, we were clicking on download the RSA provider report, and that gives you all the information for all the providers that are in that RSA or the contiguous areas for that matter. So you can look at those providers one by one. Are there any crazy records in here? Is Dr. Smith in twice? Yes, but is it Dr. Brian Smith or Dr. Jane Smith? So you can look at those on an individual level just by eyeballing them. So we haven't had any duplicates, but again, this is an almost 100% automated system. So if there are any, I just haven't seen them yet, and it's not impossible that there are. But on the RSA level, when you're actually coming back down to that level to look at an RSA, to update it, to submit it back to her shortage designation, that's when you'll be able to sort of pick those little errors up, I think.
Okay, thank you. And a final question, and this question's a bit outside the scope of this webinar, but answer it if you feel comfortable to. And this is directed to both of you. What do you expect the future of geographic HWTACs to be once more and more states start using Medicaid claims data?
I mean, I'd say, they're absolutely essential that they remain. The dynamic we see, I'll generalize where I shouldn't and say, particularly in rural areas, the shortage is often not, based on financial access. And the same even in the deepest of the urban areas, you start seeing geographic HWTACs start to work again. There has to be a system for measuring capacity. I think, to me, the future, what I've been seeing more and more of the states that I've worked with moving toward, and it's not an easy process, is a legislatively authorized licensure survey. The process of trying to get people to respond, physicians to respond to surveys, one-off for designations or even voluntarily at the statewide level is really hard. Initial response rates 30, maybe 50% if you're lucky. License-linked, legislatively mandated, board-authorized surveys, when your license is on the line, they answer, and it's not really hard. I mean, it's 10 minutes worth of information. So I'm really hoping that gets more and more traction. But again, for most states I've seen, it's not just convincing the Board of Medicine. It has to be in the Board of Medicine's scope, and often that requires legislative authorization. So I think that's if there's going to be a future. The other thing is all payer claims. We're kind of moving in that direction where you could really see capacity the same way. But with a global ruling, Supreme Court ruling against sort of all payer ERISA claims, that sort of took a hit. So I'm not sure that hopefully we'll get back on that track sometime.
Now, I'm curious about Medicaid being a federal program and this being a federal program, but Medicaid goes down to the states and then we shove it back up to the federal level again. So I'd like to see a little bit more streamlined, maybe from CMS perhaps to shortage designation or HRSA, where some of these claims per MPI can be a little bit, when I say streamlined, shortcutted quite considerably, but I'm not sure if that's in the future or not. But
that's a great point. There's a 2000 law. I forget what the actual was as a budget law for 2009. I think that mandated that the states report their claims experience up to the federal CMS level. We did some work with HRSA a bunch of years ago around the HPSA rulemaking process and got that data. Only about half the states were sort of functionally in that, from what we could tell, we're functionally doing it. But theoretically, the structure's in place and the states are supposed to be doing it. It's the same as when we call the local providers and say we're calling from the state to ask how much Medicaid you take. And they can say, well, you're calling from the state, don't you know how much Medicaid we take? So now we can do it at the state level. I agree with you totally. Ultimately, if all that claims experience flows up to the federal level and everything is checked and for integrity, theoretically that could be done centrally or analyzed, at least initial analysis done centrally.
I think we'll go ahead and end our event. With that said, I'd like to take a second to thank both our presenters. Thank you, Eric, and thank you, Barry. I thought it was some wonderful information you provided today. And as always, thank you in the audience for attending our event. We hope to see you again in the future, and have a good afternoon.